Alright guys, today we are going to differentiate deep vein thrombosis, arterial insufficiency, and nerve root compression. My name is Jake Patterson. I'm a student physical therapist, and this is Dr. Giraffe Gaines. Learning objectives for today are to identify key risk factors and clinical signs of these diagnoses, apply evidence-based screening tools such as the Wells criteria for DVT, ankle brachial index for AI, and neurodynamic testing for NRC, differentiate between vascular and neurogenic causes of lower extremity pain, recognize red flags that warrant immediate medical referral, and discuss the role of PT in early detection, conservative management, and referral strategies. So why is this important? These conditions are all common causes of leg pain. There are consequences to misdiagnosis, as a DVT can cause pulmonary embolism, which can be fatal. AI can cause limb ischemia, which may result in amputation. NRC can result in chronic neuropathy, which can result in severe functional impairment. And here's our little stats about the prevalence of each condition down below. A case study we have today, this patient actually came into the clinic a couple weeks ago. He's a 37-year-old male presenting to PT with complaints of insidious right posterior knee and leg pain persisting for 3 months. He reports a spontaneous onset of pain that has not increased or decreased in intensity. And he reports that his pain and stiffness is aggravated with walking and bending down to pick something up, and alleviated with long durations of rest. Past medical history reported as unremarkable, but patient notes a previous episode of low back pain with sciatica and a recent increase in blood pressure over the past year. His blood pressure on day 1 was 143/84, which was in the same ballpark as what it was noted as on the referral to PT. And his pain ranges from 3 to 7 out of 10. Objective exam revealed no severe limitations, but there was a 4 to 5 mmT on right knee flexion due to poor motor control. Here's some considerations for each condition. DVT will be a blood clot obstructing venous return. AI will be impaired arterial blood flow. NRC will be spinal nerve impingement, and other possibilities related to this case may be an MSK strain, compartment syndrome, or infections. So let's start with what a DVT is. So like I just mentioned, it is a blood clot in deep veins obstructing venous return. Common sites are the popliteal, femoral, and iliac veins. And then there's a triad of signs for the pathophysiology, including venous stasis, which would be from immobility and travel, endothelial damage from trauma or surgery, and hypercoagulability from cancer, pregnancy, or birth control. Risk factors, we kind of went through these a little bit here, but immobility, whether it's from post-op, long flights, or bed rest, recent trauma or surgery, cancer, pregnancy, oral contraceptives, or obesity, smoking, and clotting disorders. And then on the right, you have a few extra risk factors thrown in there. Signs and symptoms of a DVT include unilateral leg swelling, calf tenderness, and the Hoffman sign is listed as unreliable. The Hoffman sign is literally a calf squeeze test. Warm, red skin, and pain that worsens with dorsiflexion, which is bringing your toes up towards your head. Screening and diagnosis for DVT include the Wells criteria, which is pictured on the right, the D-dimer test, and the gold standard is the venous Doppler ultrasound. Red flags for immediate referral include signs of pulmonary embolism, which those signs are sudden shortness of breath, chest pain, tachycardia, and hemoptysis. So what is arterial insufficiency? It is reduced blood flow due to arterial narrowing. Causes can be atherosclerosis, diabetes, smoking, and hypertension. Some signs and symptoms of AI include intermittent claudication, which is pain in the calves that are relieved by rest, delayed capillary refill of greater than 2 seconds, cool paracyanotic skin, absent or diminished distal pulses, which would be closer to the ankle and feet, dependent rubor, which would mean the limb is pale when elevated and red when below, ulcers at toes with defined borders. And screening and diagnosis of AI includes the ankle brachial index, which is measuring blood pressure in the arm and blood pressure in the ankle, comparing those ratios to see, and then Doppler ultrasound and angiography are also used for further assessment. Red flags for immediate referral for AI include acute limb ischemia, which there's 5 P's, pain, pale appearance, pulselessness, paresthesia, and paralysis. If those are present, it might be a medical emergency. And then there's a gangrene risk, which is if left untreated, AI can progress to tissue necrosis, which is tissue death. Nerve root compression is compression of spinal nerve roots due to either disc herniation, stenosis, spondylolisthesis. There's a few causes of compression there. And then, again, common causes: herniated nucleus pulposus, lumbar spinal stenosis, DDD, and spondylolisthesis. Signs and symptoms of NRC include radicular pain following a dermatomal pattern, numbness, tingling, and burning sensations, weakness in a myotomal distribution, reflex changes, and then pain aggravated by prolonged sitting or bending forward, which typically puts more pressure on those nerve roots. Nerve root compression screening and diagnosis. So we have the straight leg raise, which is used for L4-S1 radiculopathy, and it's positive if pain occurs at less than 60 degrees of hip flexion. We have a picture of the femoral nerve stretch test, which is used for L2, L4 root involvement. We have the slump test, and then we also can use MRI and CT scans if severe neurological deficits are present. Red flags for immediate referral for NRC include Cauda-Equina syndrome, which is a severe medical emergency. Signs of Cauda-Equina are saddle anesthesia, which is numbness in where you would sit on like a horse's saddle, so kind of in between the thighs and the perineal region. Bowel and bladder dysfunction and severe bilateral leg weakness. And then rapidly progressive neurological deficits are also a huge red flag. Here's a side-by-side comparison of the 3 conditions here. So pain in a DVT is going to be aching, constant pain. AI will be kind of cramping with activity, and in an NRC we'll have shooting and burning pain. Skin color will be red in a DVT, pale in AI, and normal in NRC. Temperature, warmer in a DVT, cooler in AI, and normal in NRC. Pulses are present in DVTs. In AI it is absent or diminished, and in NRC it is normal. Swelling is unilateral and common in DVTs. No significant swelling occurs with AI or NRC. There are no associated neurological signs with DVTs or AIs, but in NRC there's reflex, sensory, and strength deficits. And then ulcers in the DVT, it is typically found in the gator region, which is kind of the medial ankle there. AI will be towards the toes, and then there should not be ulcers when it is only in NRC present. So here's a little flowchart for clinical decision making. First question to ask would be, does the patient have unilateral lower extremity pain? No, you would consider other diagnoses. If yes, then you would proceed to, is there noticeable unilateral swelling? If yes, you would start suspecting a DVT. If no, you would consider AI or NRC and kind of skip over step 3. So if there is unilateral swelling, does the patient have a greater or equal to 2 points on the Wells criteria for DVT? If yes, then there's a high probability of DVT, and you should refer out for Doppler ultrasound D-dimer testing. If no, then there's a low probability, and we should start considering the other alternative diagnoses. So if the affected limb is warm, red, then yes, the DVT may be more likely. If not, if it's cool, pale, or cyanotic, we need to suspect arterial insufficiency and proceed to step 5. If it's not warm or cool, it's just normal temperature, then we should start considering nerve root compression or other causes. If distal pulses are diminished or absent, then we need to suspect arterial insufficiency and perform an AVI. If they are intact, then we should consider NRC. If there are reports of numbness, tingling, or radicular pain following a dermatomal pattern, then we need to suspect nerve root compression and keep going to step 7. If not, then we need to consider other causes such as musculoskeletal conditions or going back through the flowchart again for venous insufficiency. And then the neurodynamic testing, if the straight leg raise is positive, then suspect lumbar radiculopathy, specifically L4 through S1. Is the femoral nerve stretch test positive, then suspect radiculopathy between L2 and L4. And if the patient has red flag symptoms, then you need an immediate referral out. And then just revisiting this case study here, I want to know what you guys think fits best, what tests you would perform first, what other questions you have about this case, and we'll kind of start a discussion down below so we can work through this case together. Now, I know what's going on with this patient at this point in time because I've seen him for a couple weeks now, but I want to see what you guys are thinking. So some key takeaways: recognize key clinical patterns, recognize red flags, and provide patient education on risk factors, prevention, and symptom monitoring. Thank you guys for listening in. Here's some references. And again, let me know what you guys think about the case study. Let me know if you have any questions in general. And you guys have a great rest of your day.